Welcome to the IRF and LTAC Virtual Training Program, Part 1, Section GG, Summary of Guidance Changes. My name is Megan Bernier. I am a physical therapist with experience in direct patient care, compliance, clinical documentation, and provider education for IRF, LTAC, and home health providers. Currently, I am the post-acute care clinical manager for Oasis Answers, Inc. I am joined today by my colleague, Ellen Strunk, who is a physical therapist who works with Acumen LLC as a clinical lead. She supports Acumen with her clinical experience across the post-acute care settings. Her background also includes functional outcomes and quality measures. During today's presentation, we will be identifying the Section GG items where there has been a change in the data element or a change in the guidance, as well as discussing guidance changes for some of the Section GG standardized data elements. As we move through the slides today, please note how the changes in the guidance are notated on the slides. Blue font will be used to identify changes in guidance. Blue font with a strike through indicates that the word or words have been removed from the guidance. The guidance changes noted in today's presentation are a result of the quarterly Q&As published over the past year and a half. The guidance from the quarterly Q&As influenced the decisions on how the guidance manuals were updated. Let's begin today's presentation by discussing a small number of changes to GG0100 prior functioning and GG0110 prior device use. GG0100 prior functioning indicates the patient's usual ability with everyday activities prior to the current illness, exacerbation, or injury. For both IRF and LTAC, please note that under the coding options, gender-neutral language has been added to Code 03 independent. In fact, all gender-specific language has been removed from the tools and the guidance manuals. The second edit made to GG0100 is specific to the IRF-PAI only. For GG0100A self-care, the word or between using the toilet and eating was replaced with the word and. This change occurred to clarify that the item is intended to collect data on the amount of assistance the patient needed for all of the listed activities in order to select the appropriate code. Additional changes for GG100 prior functioning can be found in the coding instructions. For code 3, 2, and code 1, the words any or all were added to the coding definitions. In order to code a patient as independent or 3 with prior functioning for a selected category with multiple activities, like self-care or cognitive functioning, the patient must be independent with all of the activities included in that category. If a patient requires partial assistance to complete any activities within a category, then the appropriate code would be a code 2, needed some help. If the helper completed all the activities for a patient, or the patient required the assistance of 2 or more helpers to complete the included activities, then code 1 dependent would be indicated. We also want to point out the graphic that you see on the right of slide 5. When there is additional information for your review that can be found in the guidance manuals, as is the case with this item, it will be noted with this graphic. For GG0110 prior device use, the coding instructions were updated to emphasize and clarify exactly when this item should be completed for both IRF and LTAC. So for GG0110 prior device use, this item should be completed during the 3-day assessment period. As a reminder, GG0110 prior device use is a check all that apply item, meaning all listed devices that the patient used previously should be checked. In this section, we are going to review the item set changes and then guidance changes that apply to all of the GG0130 and GG0170 items. In later sections, we will review changes to item-specific guidance. This slide illustrates a summary of changes made throughout the manual pages for GG0130 and GG0170. They include clarification of item rationale, revised steps for assessment, new and revised definitions, new examples included in coding instructions, clarifications of decision tree instruction, the addition of new coding tips, and addition of examples of probing conversations. The examples throughout section GG will be very helpful since they provide further clarification of the intent of the item coding. Next few slides contain illustrations of the updated GG items. Here on slide 9 is GG 0130 for IRF. The main updates are the change to gender-neutral language to the coding scale and some refinement to the item descriptions. This is an illustration of the LCDS version of GG 0130 self-care. And this is GG 0170 from the LCDS 5.0, which has 6 new items. The first new item highlighted on this slide is GG 0170G car transfer. Slide 12 has the remaining 5 new items, which include GG 0170L, walking 10 feet on uneven surfaces, 3 items specific to step activities, GG 0170M, 1-step curb, GG 0170N, 4 steps, and GG 0170O, 12 steps, and finally, GG 0170P, picking up object. Now that we've briefly reviewed the changes to the instrument, let's look at the guidance language changes. One of the biggest changes providers can expect to see when they review the initial pages for GG 0130 and GG 0170 is that they will find the item rationale as well as the steps for assessment and the general coding tips have been combined to include both GG 0130 and GG 0170 language, rather than having a lot of duplicative language in both sections. For example, we can see that the item rationale has been enhanced with the addition of this language in blue text to include mobility limitations, making it now relevant to both GG 0130 self-care and GG 0170 mobility. Important clarifications were made to GG 0130 and GG 0170 assessment approaches. When assessing GG 0130 and GG 0170, the patient should be allowed to complete each activity as independently as possible as long as they are safe. This is true regardless of how the patient performed the activity prior to the current illness, exacerbation, or injury. For example, if the patient was standing prior to perform their oral hygiene prior to their current illness, exacerbation, or injury, they would not necessarily have to be able to stand during our assessment to score the item with a performance code. If we allow the patient to complete each activity as independently as possible, as long as they are safe, regardless of how the patient performed the activity previously, then the assessment of the patient performing oral hygiene could be conducted in either sitting or standing. Additional guidance around use of assisted devices has also been added to the manuals. Activities may still be completed with or without an assisted device, including the use of any new or previously utilized assisted devices or equipment. The guidance acknowledges that the use of a device or piece of equipment may result in the patient needing less assistance from a helper. But this makes sense since the guidance instructs that the patient be allowed to complete each activity as independently as possible. So for instance, if we provide the patient with a walker, and that allows the patient to ambulate without the assistance of a helper, and this also represents them performing the activity as independently as possible, then we select the code based on how they ambulate with the walker. Clarifications on what we are assessing in terms of the patient performance have also been made. If helper assistance is required for the patient to complete an activity, then code based on both the type and amount of assistance provided. This edit is more consistent with the coding scale, which addresses not only amount, but also different types of assistance. Questions from the quarterly Q&As have addressed how the first use of an assisted device impacts the performance of the GG 0130 and GG 0170 activities. The guidance states a patient can be assessed and an activity coded with a performance code based on the first use of an assisted device or equipment that has not been previously used. So continuing with our example from the previous slides, where a patient was provided a walker to ambulate safely in order to walk 10 feet, even if this patient had never used the walker before, a clinician can still code GG0170I, walk 10 feet, based on the type and amount of assistance the patient required to complete the activity with the walker. At admission, the performance code should reflect the patient's baseline performance, which should be determined prior to the benefit of services. Prior to the benefit of services means prior to the provision of any care by your facility staff that would result in more independent coding. Introducing a new device should not automatically be considered as providing a service. So whether a device used during the clinical assessment is new to the patient or not, clinicians should be coding based on, again, on the type and amount of assistance that is required for the patient to complete the activity. With our example from the previous slide, providing the new walker to our patient would not automatically be considered providing a service. In other words, if the patient couldn't ambulate without the walker, we shouldn't automatically select an activity not attempted code when the patient could be assessed based on their first use using that walker. On the opposite side of the spectrum, there will be patients that cannot complete activities prior to the benefit of services. For these scenarios, this new coding tip reminds us that there are multiple assessment strategies that can be utilized before we automatically select an activity not attempted code. We can determine patient performance from observation of the activity. If that is not an option, we may be able to determine performance based on patient caregiver report, collaboration with other facility staff, or via assessment of similar activities. If, after determining that a patient cannot complete the activity prior to the benefit of services, and the performance code cannot be determined using the additional assessment strategies, then selecting the appropriate activity not attempted code would be appropriate. Slide 19 describes new guidance that states we should be assessing the GG0130 and GG0170 items based on the patient's performance of the activity. This is true regardless of whether or not the activity is being or will be routinely performed. For example, if we have a patient who we are sending home from a facility with the recommendation that they do not ambulate, but while in the facility they are able to safely ambulate with our assistance, then we code the item based on the type and amount of assistance they need to complete the activity. We would not want to use one of the activity not attempted codes just because they will not be performing the activity once they leave the facility. Code 04, supervision or touching assistance for the GG items, includes verbal cueing. When performing patient assessments, it is important to differentiate between communicating an activity request verbally from verbal prompts that would be considered necessary for the patient to safely complete the activity. Recent quarterly Q&As clarified that communicating an activity request, like, can you stand up from the toilet, or can you transfer to the chair, would not be considered verbal cueing for the purposes of coding a patient. However, if verbal prompts or instruction are needed for the patient to complete the activity safely, for example, push down on the grab bar or stand closer to the walker, then the assessing clinician would need to consider those cues in their scoring and determine the most appropriate code utilizing the Section GG decision tree. To cover guidance changes specific to the GG codes, I will turn the presentation over to Ellen Strunk now.
Thank you, Megan. Let's look now at the updated instructions for a few of the Section GG 0130 and 0170 performance codes. When we are completing an admission or discharge assessment, we want to complete that assessment as close to the time of the respective admission or discharge as possible. That is because the intent is to capture the patient's baseline ability at admission and to capture the amount of change the patient has made at discharge. Code 05 setup or cleanup assistance is used when the patient only requires assistance prior to or following the activity, but not during the activity. The example provided is just that, an example. Other assisted devices could be used as well. Code 04, supervision or touching assistance, is selected if the helper has to provide verbal cues and/or touching, steadying, and/or contact guard assistance during completion of the activity. This assistance may be provided throughout the activity or intermittently. Note that there were changes made to the language. Contact guard assistance was previously considered incidental help, but that has now been removed. If the patient is able to perform the activity with either contact guard or steadying assistance, then it is coded with code 04. It was also clarified that code 04 supervision or touching assistance is also appropriate if the patient requires only verbal cueing to do the activity safely. An example was added to provide clarification to code 03, partial moderate assistance. If the patient requires minimal assistance from a helper to support partial weight bearing during sit to stand, this would be considered partial or moderate assistance. Code 02, substantial or maximal assistance, also has an example update. In the example provided, if the patient is only able to wash their left arm and chest and requires a helper to complete all of the remaining bath, this would be considered substantial maximal assistance because the helper does more than half of the effort to complete the activity. Code 01 dependent has two new coding instruction updates to clarify when code 01 is indicated. Code 01 is indicated if when an activity is completed, the helper is performing all of the effort. It's also indicated if two or more helpers are required for the patient to complete the activity. Clarification was added that even if a second helper is only providing supervision or standby assistance and no actual hands-on assistance, if the person assessing the patient determines the second person was necessary in order to complete the activity safely, the patient would still be coded with a code 01 dependent. Additionally, if a patient requires two helpers, one to provide support to the patient and a second to manage a device or piece of equipment to complete the activity, the same principle applies. If they are both needed, the patient is coded as dependent 01. As mentioned before, the activity not attempted codes should only be utilized after we've exhausted all of our assessment strategies, including observation of performance, patient caregiver report, collaboration with other facility staff, and assessment of similar activities. An activity not attempted code should only be used when, after the use of all provided strategies, we're still unable to determine the appropriate performance code. So let's look more closely at those activity not attempted codes. Code 07, patient refused, is used if the patient refused to complete the activity. Code 09, not applicable, is indicated if the patient did not perform this activity prior to the current illness, exacerbation, or injury, and the activity was not attempted at assessment. Code 10, not attempted due to environmental limitations, is when the patient did not attempt the activity due to environmental limitations, such as lack of equipment and/or weather constraints. Code 88, not attempted due to medical condition or safety concerns, if the activity was not attempted during the assessment time period due to the patient's medical condition or other safety concerns. This code is only appropriate when the patient could perform the activity prior to the current illness, exacerbation, or injury. For example, if the patient has a non-weight-bearing medical restriction that prevents the patient from performing the stair activities during the assessment time period, but the patient could go up and down stairs prior to their current illness, exacerbation, or injury, then code 88 would be appropriate. If the patient never went up and down stairs prior to the current illness or injury, then code 09, not applicable, is the most appropriate choice. Decision tree instructions were also updated. The decision tree is utilized to help select the appropriate code to capture a patient's performance based on the type and amount of assistance the patient needed to complete the activity. New language was added to the introduction of the decision tree, and this language reinforces the guidance that we've talked about on when the ANA code should be used. As we know, there may be times when we are unable to see a patient complete an entire activity. For example, the patient is asked to perform a shower and they do a portion of the shower activity, but then refuse to do the rest, or we only see a patient transfer into a car, but not out. If this happens and the patient has not completed the entire activity during the assessment time period, clinicians should use their clinical judgment to determine if the situation that was observed allows them to adequately assess the patient's ability to perform that activity. If it's determined that this observation is adequate, then code based on the type and amount of assistance the patient requires to complete the entire activity. However, if the clinician doesn't feel like the observation of the partial activity provided adequate information to support a performance code, and the rest of the activity performance code couldn't be determined from other assessment strategies, then the clinician would select the appropriate activity not attempted code. This being said, if an activity is not entirely completed during one clinical observation, the code selected should still report the patient's ability to complete an entire activity. For example, if we assess a patient transferring from bed to chair, but the patient won't be moving back from the chair to bed until later that night, the code for chair bed to chair activity could still be selected based on the type and amount of assistance required to complete the entire chair bed to chair activity. At admission, select a minimum of one discharge goal for the GG items. Once a discharge goal has been established on the IRF-PAI or LCDS, there is no need to go back and update that goal even if the patient status changes or there is more information collected during or after the admission time period. The change, however, may impact the patient's plan of care, and so that document may be updated. If an activity is coded with an activity not attempted code, it is acceptable to select a code 06 through code 01 for that discharge goal if the patient is anticipated to be able to perform the activity by discharge. So taking the previous patient who is non-weight bearing at admission with a code 88 for the stair activities, if we know the non-weight bearing restrictions would be lifted in a few days, a discharge goal for the stair activities could still be set. Now that we have covered the overarching coding guidance that applies to all of the GG 0130 self-care items and GG 0170 mobility items, let's turn to the guidance specific to self-care by going through the different individual item changes. These changes will apply to both IRF and LTAC. GG 0130A assesses the patient's ability to use suitable utensils to bring food and/or liquid to the mouth and swallow food and/or liquid once the meal is placed before a patient. However, assistance with tube feedings or parenteral nutrition is not considered when determining final code selection for this item. We do want to point out guidance specific to that act of swallowing. The item intent for GG 0130A includes the patient's ability to swallow food and/or liquid. However, if a patient can swallow safely without assistance, then exclude swallowing from consideration when coding GG 0130A, eating. Swallowing is only considered when the patient requires assistance to swallow safely. If they do, then select the code based on the type and amount of assistance needed for both feeding and safe swallowing. For example, if your patient requires a verbal cue to tuck their chin in order to safely swallow, that cueing would be factored in to your coding decision for GG 0130A. You will find other new coding tips for GG 0130A. For example, if a patient uses finger foods and uses their hand, a code is still selected based on the type and amount of assistance the patient requires. The fact that the patient is not using any utensils does not factor into the coding. For example, if the patient eats finger foods with their hands independently and they need no help or assistance at any point, the patient would be coded as 06, independent. Additionally, if the patient is only taking fluids by mouth, the performance code for GG 0130A is based on the patient's ability to bring liquid to the mouth and swallow liquid once the drink is placed in front of the patient. For GG 0130B, oral hygiene, there is new guidance for both IRF and LTCH relative to edentulous patients. If a patient is edentulous, they have no teeth, but GG 0130B can still be coded based on the type and amount of assistance required to clean the patient's gums. The point is that even if a patient does not have teeth or dentures, it does not automatically mean the patient must be scored with an activity not attempted code. GG 0130C looks at the patient's ability to manage their clothing and perineal cleansing before and after voiding or having a bowel movement. Activities that take place before and after the patient uses the toilet commode, bedpan, or urinal. If the patient completes a bowel toileting program in bed, GG 0130C toileting hygiene can still be coded based on the type and amount of assistance needed for managing clothing and perineal cleansing. These activities can also be assessed regardless of whether or not the patient actually has the need to void or have a bowel movement at the time of assessment. We are now going to transition to some guidance changes that apply to GG 0130 self-care, but only in the IRF setting. These are changes specific to the shower, bathe, self, upper lower body dressing, and footwear items. GG 0130E, shower, bathe, self, looks at the patient's ability to wash, rinse, and dry their entire body. It does not include transferring in and out of the tub or shower or onto or off a tub bench. The clarified guidance is that the patient's ability to shower or bathe themselves can be assessed from any location where the activity is taking place. For example, it could be shower or tub, or at the sink, or in bed, or maybe the patient has a full body sponge bath. The location of the activity does not impact the coding. We are still instructed to code based on the type and amount of assistance needed to complete the activity, regardless of where the activity occurs. For example, if the patient can complete all of their bathing tasks independently, but requires a helper to retrieve the supplies necessary to perform the included tasks, then code 05, setup or cleanup assistance, would be the appropriate code. The assistance is being provided before the activity begins, but not during the activity. Another revised coding tip is that 05, setup or cleanup assistance, would be selected if the only assistance the patient needs is to cover a wound or device for water protection prior to beginning bathing. As we talked about earlier, if a patient is only completing a partial bath or simulating a bath, and the partial bath or simulation allows the clinician to adequately assess the patient's ability to complete the activity, then GG 0130E can be coded with a performance code. Additionally, the guidance pertaining to a patient who is unable to bathe their entire body because of a medical condition has been revised to include an example of what could be considered a medical condition. That is, a non-removable cast or dressing. When present, the guidance already discussed is still applicable, and the appropriate 06 through 01 performance code can be determined. Next is GG 0130F, upper body dressing, GG 0130G, lower body dressing, and GG 0130H, footwear. Some of the new guidance added to the IRF-PAI manual clarifies that if a dressing item covers all or part of the foot, then it is considered when assessing GG 0130H footwear. It's not considered when assessing lower body dressing. For example, if a patient had an AFO that covered the foot and extended up the length of the leg, the AFO would be considered in the assessment of GG 0130H footwear. Also, GG 0130H considers the patient's ability to safely put on and take off shoes and socks that are safe for mobility. However, if the patient wears only shoes or only socks and they are safe for mobility, then GG 0130H, putting on and taking off footwear, would still be code based on that singular item. And then one last piece of revised guidance for the dressing activities to point out. If the patient requires assistance with buttons, fasteners, and/or fastening a bra when dressing, then code based on the type and amount of assistance required to complete the entire dressing activity. So at this point, I'm going to turn it back over to Megan to cover the mobility items.
Thank you, Ellen. For the remainder of the presentation, we will be covering the changes for GG0170 mobility items for both IRF and LTAC. We will be describing the changes in the guidance, as well as identifying the new items for the LCDS. This slide lists the 6 new GG0170 items being added to version 5.0 of the LCDS instrument. As we previously discussed, the new items include GG0170G, car transfer, and GG0170L, walking 10 feet on uneven surfaces. There are also the 3 new stair items, GG0170M, one-step curb, GG0170N, 4 steps, and GG0170O, 12 steps. And finally, GG0170P, picking up object, is also new. For additional training, there are video tutorials available on the IRF-QRP training site for GG0170L and GG0170P. These trainings include an overview of the items and how to code the items appropriately based on examples provided in the videos. Let's begin by first reviewing the GG0170 bed mobility items, which has revised guidance for both IRF and LTAC. The guidance found in GG0170C, lying to sitting on side a bed, that states clinical judgment should be used to determine what is considered a lying position for the patient, has now also been applied as guidance for GG0170A, roll left and right, and GG0170B, sit to lying. For example, if a patient has a medical condition that requires them to lie in a slightly elevated resting position, the assessing clinician can determine if this slightly elevated resting position constitutes lying for a patient. If they do determine it to be lying, then the clinician could still code any of these 3 items with a performance code. However, if at the time of the assessment, the patient is unable to lie flat due to medical conditions or restrictions, but they could lie flat prior to the current illness, exacerbation, or injury, then this should be reflected with a code 88, not attempted due to medical conditions or safety concerns. An example of this would be if the clinician determines that the patient needs to sit in an upright sitting position rather than in a slightly elevated position. There have also been new examples added to the guidance manual pages that enhance the clarification of these concepts, so you will want to refer to those as well. Additional language for GG0130A reiterates that if the patient determines bed mobility cannot be assessed because of the degree to which the head of the bed must be elevated, then the appropriate activity not attempted code would be selected. This may not just be code 88. The assessing clinician would also have to determine if any of the other activity not attempted codes would be appropriate. GG0170B, sit to lying, looks at the patient's ability to move from sitting on the side of the bed to lying flat on the bed. This can be assessed from the patient's preferred or necessary sleeping surface. For example, if a patient does not sleep in a bed and prefers to sleep in their recliner, their ability to complete the activity from the recliner can still be assessed. With GG0170C, lying to sitting on side a bed, there is a change in the item description itself. Currently, the description includes that once the patient is in a seating position, the assessment includes feet flat on the floor. In the revised version, that language and concept have been removed, and the item now states that the patient should end the activity sitting on the side of the bed with no back support. This is to accommodate patients who are of short stature or who have bilateral lower extremity amputations and therefore do not have the ability to place both feet flat on the floor. A performance code can still be selected if a patient can sit on the side of the bed without both feet flat on the floor. GG0170D, sit to stand, has new guidance that clarifies this is a sit to stand activity beginning from any sitting position. If the patient requires a helper to retrieve an assisted device or adaptive equipment, such as a walker or an AFO, and that assistance is required before the patient can complete the activity, and then no further assistance is necessary during the activity, then code 05 setup or cleanup assistance would be indicated. Revised guidance for GG0170D was also made to the coding tip related to the mechanical lift. If a patient uses a mechanical lift to transfer from bed to chair, and even with assistance, they are not able to complete the sit to stand activity, then code GG0170D with the appropriate activity not attempted code. Conversely, if the patient is using the sit to stand lift to get to a standing position, and the patient requires the assistance of two helpers to get from that sitting to standing position, then code GG0170D as code 01 dependent. The new guidance for GG0170E, chair bed to chair transfer, states that a stand pivot, squat pivot, or a slide board transfer could all be used to complete the activity. Ideally, the transfer should be assessed in an environment where taking more than a few steps would not be necessary to complete the transfer. And if the patient uses a recliner as their preferred or necessary sleeping surface, then the activity should be assessed based on the patient's need for assistance using that sleeping surface. The changes to guidance also clarify when this activity begins and ends. It begins with the patient sitting on the edge of their bed or alternate sleeping surface, and ends with the patient sitting in a chair or wheelchair. It is important to remember that for GG0170E, that even if only one portion of the activity is assessed, the code selected is based on the type and amount of assistance the patient needs to complete the entire activity. GG0170F, toilet transfer, looks at the patient's ability to get on and off the toilet. Just like with toileting hygiene, the transfer on and off a toilet can still be assessed and coded with a performance code, even if the patient does not need to void or have a bowel movement in conjunction with that transfer. It is also important that for GG0170F, the activities of toileting hygiene, clothing management, and transferring on and off a bedpan are not considered part of the assessment for GG0170F. GG0170G, car transfer, is a new item for LTAC providers. So this guidance is considered new for LTAC and revised for IRF. This activity includes the patient's ability to transfer in and out of a car or van seat on the passenger side. A clarification for the assessment of GG0170G is that it can take place in any vehicle model available at the time of assessment. The patient's ability to get to or from the vehicle, along with opening, closing the car door, or fastening, unfastening the seatbelt, is not considered when assessing a patient's ability to complete the car transfer. The car transfer is only the patient's ability to get in and out of the car on the passenger side. There is new guidance for this item which states that a patient who remains in their wheelchair and does not transfer in and out of the car or van seat should be coded with the appropriate activity not attempted code. This scenario is considered to be the patient not completing the activity. There could also be patients who require a walker or a walking device to get to and from the car, but they do not require the use of that device for the transfer in and out of the car. If this is the case, then any setup and or cleanup of this assisted device would not be considered when coding GG0170G. Only consider assistance with the use of that walker, if it is required to complete the transfer in and out of the car or van passenger seat. Guidance discussed previously also applies to GG0170G. That is, if a clinician observes a patient only perform a portion of an activity, they can use clinical judgment to determine if that is enough for them to adequately assess the patient's performance of the entire activity. So if a clinician is only able to assess the patient getting into the car, they can determine if that was enough information to determine how the patient would also get out of the car and complete all of the activity. Additionally, GG0170G can still be coded using a performance code when a patient has a medical restriction. For example, if the patient has to sit in a long sitting position and can slide into the back seat maintaining that position, then GG0170G can be coded with a performance code. Then our final bullet point on this slide is reinforcing the concept that a clinician should only be turning to those activity not attempted code options after it is determined that the car transfer was not completed by the patient, and the patient's performance could also not be determined based on patient caregiver report, collaboration with other facility staff, or assessment of similar activities. To cover the remaining slides, let me turn the presentation back to Ellen.
Thanks, Megan. We're going to transition now to some guidance that will apply to GG0170 walking items. Both the IRF-PAI and LCDS guidance manuals now have a new section that combines general guidance for all the walking items. The guidance points out that the assessment of the walking activities begins once the patient is in a standing position. Any assistance getting into a standing position would not be considered in scoring these items. An important point is that the walking activity cannot be considered completed without some level of patient participation. In other words, a helper cannot complete a walking activity for a patient. The patient must be able to ambulate the entire stated distance. For example, if a patient walking 50 feet with 2 turns needs to take a brief standing break during the activity, they can. However, if they need to sit down and rest before they can complete the entire stated distance, the patient is unable to complete the activity and an activity not attempted code would be selected. Clinicians should use clinical judgment to determine how the actual patient assessment of walking is conducted. If the assessment of those walking activities is completed through combining the walking activities and the patient completes one longer distance, then use clinical judgment to determine the type and amount of assistance needed for each individual activity. Guidance was added to emphasize that when assessing activities that overlap or occur sequentially, clinician judgment is used to determine the type and amount of assistance needed for each individual activity. That being said, all of the GG walking activities do not need to occur during a single session. They can be assessed at separate times. While guidance states that activities may be completed with or without an assistive device, the walking activities cannot be coded with a performance code if the patient was only able to complete the activity using a device that is restricted to patient use during therapy sessions. Examples of these include parallel bars, an exoskeleton or overhead track, and harness system. So if a patient can only complete the activity by using one of those devices, then the activity has not been completed. As with other items, if the patient completes the entire walking distance, but requires the assistance of 2 helpers to complete the activity, then the assessment is coded O1 dependent. And if the patient requires help to complete the walking activity, but only for the helper to retrieve and place the walker and/or put it away after they use it, then that would be considered as setup or cleanup assistance and scored with O5 supervision or cleanup assistance. GG0170L, walking 10 feet on uneven surfaces, is a new item for the LCDS and slightly revised for the IRF-PAI. Here we are looking at the patient's ability, beginning from a standing position, to walk 10 feet on uneven surfaces. This activity can be completed outside or inside. Examples of uneven surfaces include sloping surfaces, turf or gravel, but the clinician should use their clinical judgment to determine what type of surface is uneven. When assessing the GG0170 stair step items, consider this. Completing the stair activities means that a patient goes up and down the stairs by any safe means, with or without any assisted device and with or without assistance. Examples of assisted devices that can be used include a railing or a stair lift. Going up and down stairs by any safe means could also include the patient who is safely bumping or scooting up and down the stairs on their buttocks. In other words, it is not limited to a patient who walks up and down stairs on their feet. Ascending and descending stairs does not have to occur sequentially or even during one session. If the assessment of going up the stairs and then down the stairs does occur sequentially, the patient may take a standing or seated rest break between ascending and descending the 4 steps or 12 steps and still be coded with a performance code. A patient who is a wheelchair user may be assessed going up and down stairs, including 1 step or curb in a wheelchair. The code should be chosen based on the type and amount of assistance required from the helper. Guidance was added to state that the activity begins once the patient begins up or down the steps. The activity of getting to or from the stairs is not included in the assessment of the stair items. In this slide, we want to point out that there was a data element change in the IRF-PAI for GG0170M, 1 step or curb. In the current version, GG0170M is described as the ability to go up and down a step and or up and down 1 step. In the revised version, the and is removed and it now reads as up and down a curb or up and down 1 step, meaning both the step and curb do not need to be assessed for GG0170M. However, if the patient is assessed on both, going up and down a single step and up and down a curb, and there's variation in their performance, then code GG0170M 1 step or curb based on the activity with which the patient requires the most assistance. GG0170P, picking up an object, is new for the LTAC, and there is some revised guidance for IRF. This item looks at the patient's ability to bend or stoop from a standing position to pick up a small object, such as a spoon, from the floor. GG0170P must be assessed while the patient is in a standing position. If a patient is unable to stand, then this activity would not be considered as occurring, and the appropriate activity not attempted code would be used. However, if a standing patient is unable to pick up a small object off the floor and they require the helper to pick up the object, then code 01, 02, or 03, depending on whether the helper is providing all the effort, more than half the effort, or less than half the effort. Clinicians will have to use their clinical judgment to apply the coding definitions and guidance regarding how much the patient is participating. And just like with all GG0170 activities, a patient may use an assisted device or a piece of adaptive equipment to complete this activity and still be coded with a performance code. For example, the patient could use a cane to steady themselves and bend over to reach the object on the floor, or they could use a reacher to grab the object. The clinician would just code on the type and amount of assistance the patient required. GG0170Q1, does the patient use a wheelchair or scooter, is our first wheelchair item. And this item is the question that determines whether or not the remaining wheelchair items are assessed. In the current manual, the guidance is to code the item for patients who are learning how to self-mobilize. The guidance has now been updated to say the intent of the wheelchair mobility items is to assess the ability of patients who are using a wheelchair under any condition. Therefore, the only time a 0 no would be selected is if at the time of the assessment, the patient does not use a wheelchair or scooter under any condition. For the wheelchair items, GG0170R and S, a helper can assist a patient to complete the wheelchair distance or make turns if required. So unlike the walking items, if a patient is unable to wheel the entire distance themselves, the activity can still be considered completed and coded with a performance code if the helper assists the patient to complete the entire stated distance. If a patient uses both a manual and a motorized wheelchair or scooter at the time of the assessment, the clinician should code the activity based on the type of wheelchair scooter with which the patient requires the most assistance. For example, if a patient requires more assistance to mobilize in the manual wheelchair, then GG0170R and S would be coded based on the type and amount of assistance needed to mobilize the manual wheelchair. This concludes our presentation for today. We hope you have found this overview of the refinements and new guidance helpful. As we mentioned, there have also been revisions to some of the Section GG prior functioning self-care and mobility items and associated guidance. There are also new GG0170 mobility items for LTAC. We would encourage you to take a look at the posted manuals in order to familiarize yourself with all of these new changes and additions. If you have questions about this presentation, please submit them to pactraining@econometricainc.com by June 3rd, 2022. Select questions will be discussed in a Q&A session during the June 2022 virtual live event. Thank you for joining us today. Again, we welcome questions submitted to this email address on the slide, and we look forward to seeing you at the virtual live Q&A session to be held in June.